So good evening, colleagues. We'll start and hope the others will join us as we continue. So following popular demand, we're going to continue with the topic for last week, common complications in anesthesia. I saw from the polls that majority of us want us to conclude on this very important topic. So I've yielded to it, and we'll go through them. Hopefully we'll be able to finish them. All right, we looked at the linear outcomes already, so let's just go. We did say that complications in anesthesia are uncommon, but they remain a critical concern for all of us in the perioperative team. So as a result, we must be prepared as anesthesiologists to anticipate, to recognize and promptly manage these adverse events when they occur in order to prevent mortality and morbidity. And we said there could be different reasons for complications in anesthesia. One of them is human error. All right. And this could be due to an unskilled anesthetist or non vigilant anesthetist. Anesthetist may be fatigued, or you don't have a skilled assistant. And more importantly, poor patient preparation. Or equipment failure do occur, especially in regions where we still have epileptic power supply and unstable backup. All right, it could also be a result of failures of breathing system. And sometimes complications do arise from poorly controlled comorbidities. And all right, all these things can lead to avoidable complications. So we looked at different classifications, all right, airway complications, respiratory, cardiovascular, neurological, temperature-related, drug reactions, and positioning. We attempted all these case-based MCQs the last time. We won't go over them. All right, we looked at the can't intubate, can't ventilate scenario. Okay, and we did say that commonly seen in cases of unanticipated difficult airway. All right, difficult airway does not kill. All right, but when you can't intubate and you can't ventilate the patient, it becomes a problem. All right, usually as a result of unanticipated difficult airway, difficult mask ventilation, difficult laryngoscopy, difficult intubation. So when you face a CICV situation, you need to shout for help. All right, by all means, oxygenate this patient with 100% of oxygen. We have said that failure to intubate or ventilate does not kill the patient. What kills the patient? Failure to oxygenate. So by whichever way, try to oxygenate, you can do in front of neck access. So just get oxygen into the patient by all means. And wake up the patient, okay? If the surgery is not a dire emergency. Okay, we looked at laryngospasm, and we said that laryngospasm is due to involuntary spasm of vocal cords, leading to complete or partial obstruction. And spasm is the common causes, surgical stimulation under light anesthesia. We did say last week that you are the safety officer of the OR, so you don't allow surgeons to start until you are ready. All right, pharyngeal secretions, patient might have aspirated, all right, gastric contents. There could be secretions in the oropharynx. And even the anesthetist, when you're trying to do laryngoscopy where your patient is not fully relaxed, this can lead to laryngospasm. All right, suprametonium comes handy, pharyngeal suction gentle. All right, you can deepen anesthesia, all right, and do some airway manipulation to relieve obstruction. And we did talk about the spasm notch pressure, all right, the last some point pressure, and you monitor oxygen. And we did say that this is a very important way to relieve spasm. Okay, you put your pressure at the laryngospasm notch or the Larson's point. Like we said the other time, is between the base of the skull and the mastoid process. Okay, and you put pressure bilaterally. All right, it relieves the spasm. Okay, we talked about all of this. And let's go to respiratory complications. We answered all this. We talked about this. I'm just going to select one of them. The one very important respiratory complications in pneumothorax. All right, even this last week, I had a patient, an ICU patient, who was taken to the OR for elective tracheostomy following prolonged intubation. And the patient developed bilateral tension pneumothorax intraoperatively. All right, so pneumothorax is a very important complications during anesthesia. All right, so the presence of air in between the visceral and parietal pleura, which can lead to either partial or complete collapse of the lung. All right, so it's classified as either spontaneous, all right, which could be primary due to without underlying lung disease, or secondary, where the patients can have underlying lung disease like COPD, your asthma, whatever it is. It could be traumatic pneumothorax. This could be due to blunt or penetrating chest trauma, rib fractures, especially with your flat chest. Atogenic, all right, during central line disruption or initiation of intermittent positive pressure ventilation. So tension pneumothorax occurs when the air within the pleural space cannot come out and leads to increased interthoracic pressure, lung collapse with mediastinal shift, and associated cardiovascular collapse. So tension pneumothorax is actually a dire emergency that needs to be relieved as soon as possible. Right, so I mentioned some of these things: barotrauma during positive pressure ventilation. It could be surgical trauma during tracheostomy. All right, so it's important for you to recognize pneumothorax. So how do you recognize it? Sudden, when a patient has sudden desaturation and is because it's hypotensive at the same time. Sudden desaturation and hypotension. And when you listen to the chest, all right, absent breath sounds on one side or both sides if it's bilateral. All right, you have high airway pressures on your ventilator. All right, and you can also see subcutaneous emphysema with crepitus. Okay, and one of the ways to actually make a diagnosis, you can do your lung ultrasound, bedside lung ultrasound, where you will see absent lung sliding. All right, and this is what we did for this patient. All right, we saw the subcutaneous emphysema. The thorax was very, very highly enlarged. Okay, and on lung ultrasound, we confirmed pneumothorax with absent lung sliding and the presence of the lung point. All right, and we were able to manage that patient. So what do? Don't wait for the cardiothoracic surgeon or the surgeons to come. So if it's tension, all right, you need to do immediate needle decompression. All right, just locate the second intercostal space in the mid clavicular line. You use a 16G cannula, all right, and you put it there, avoiding the neurovascular bundle, okay, and you'll see air gouge out, okay. If it's both sides, you do it. You can also use the fourth or fifth intercostal space in the anterior axillary line. All you want to do is get the air out so that they can ventilate and you can relieve their cardiovascular collapse. This is important, and this is what we did. Eventually, we inserted a bilateral intercostal chest drain, and the patient improved, although the patient is still in the ICU. So pneumothorax is a very, very important complications during anesthesia. All right, so we looked at atelectasis, we looked at all this, the need for us to recruit the alveoli. All right, we talked about this. So cardiovascular complications, hypertension occurs, especially at induction. Okay, when you give them, sometimes some people are very bold, they give 4 to 5 milligram per kg of propofol. All right, and even tapentol, sometimes you can have sudden hypotension at induction. So what you normally do is to just make sure that you give bolus, especially in critically ill patients that have already physiological hypoxia or hypotension. So induction of anesthesia, during neuralgia anesthesia, you put your spinal and the patient become hypotensive almost immediately. Hypotension can occur intraoperatively during surgery from either inadequate fluid resuscitation or right during emergency or blood loss. And this is important. Sepsis and cardiac dysfunction could also be cause of hypotension during surgery. So how do you manage this? Reduce anesthetic depth, okay, and give aggressive fluid bolus with your crystalloids. And if you have the suppressors, which you should, you have your phenylephrine in case of sympathectomy, ephedrine, and noradrenaline comes handy. But if the cause is cardiac, all right, you can make sure you use your dobutamine or other inotropes that you have available. So hypertension is a very common, complications during surgery. So hypertension also occurs. We've talked about all of that. And cardiac arrest on the table is a very common um, complications. And when you have cardiac arrest, maybe from prolonged hypotension or hypoxia, all right, hypovolemia, we can have electrolytes. So always look for the cause. Once you have a cardiac arrest, immediately you need to, start the ACLS protocol, all right, and look for the treatable causes and ensure that you take this patient to ICU for post-resuscitation care. All right, so neurological complications. We talked about this and stroke, but I want to focus on delayed recovery from anesthesia, delayed recovery. When do we say a patient is having delayed recovery from anesthesia? All right, when a patient fails to regain consciousness within 15 minutes after completion of anesthesia, you could be asked, when a patient fails to regain consciousness within 15 minutes after completion of anesthesia, that is delayed recovery. All right. Normally, patients under general anesthesia should recover from anesthesia when the alveolar anesthetic concentration decreases to about 30% of the minimum alveolar concentration of your inhalational agent. All right. So when a patient fails to recover after 15 minutes of switching off your inhalational agent and your recovery, your reversal of your residual muscle paralysis, I would say this patient has delayed recovery. So there are three different phases of recovery from anesthesia. We have the immediate recovery. All right, this is what I usually like. When I used to be, do more of anesthesia, I always like my patient to wake up with the last stitch. Okay, so this requires vigilance. You're monitoring, you are discussing with the surgeons, especially in emergencies where you don't want the patient to be under anesthesia for a prolonged period of time. Engage your surgeons. How many stitches do you have left? Okay, how many minutes do you have left? And you begin to reduce your inhalation agent accordingly. So a patient should recover, all right, within 5 to 10 minutes. All right. Most of the times I'm extubating the patient while the surgeon is still on scrubbing. And this is important, especially in places where you have high turnover of patients. Okay, maybe day case procedures also. You want the patient to recover immediately at the end of anesthesia and surgery. Sometimes we have intermediate recovery where there's a regain of power of coordination, but the patient is not fully recovered. And sometimes recovery from anesthesia may take hours or even days. Okay, and we need to understand it. All right, what are the common causes? All right, I said the patient hides under anesthesia, hide. Okay, so heavy premedication. All right, when you premedicate this patient heavily, remember that premedication is usually strictly referred to medications that is administered within 30 minutes to 1 hour before anesthesia. So heavy premedication, patient with hypoglycemia, all right, hepatic disease, or patient may be hypothermic, especially in, um, in theater where you do not have a controlled temperature. Always try to ensure you have a thermoneutral environment in the OR. Some patients can have intracerebral hemorrhage, especially in pediatric age group. And for prolonged length of anesthesia lasting more than 2 hours, 3 hours, 4 hours, these are recipes for delayed recovery from anesthesia. Drug overdose. All right, drug overdose or patients with hepatic or renal disease in which is the metabolism of your drug is impaired or delayed. All right, this can also lead to delayed recovery from anesthesia. Enzymes abnormality like your choline apnea or patients that have electrolyte derangement, okay, from every type. Don't forget elderly patients, okay, they have reduced ability to metabolize, your anesthetics. So it's important, all right? Your MSC for elderly patients should be much lower, actually, in all the medications you give them. So you have a case of delayed recovery in your hands. How do you manage? It's important. Don't panic. Okay, a systemic approach is usually very essential. Go through your ABCD approach, look at the airway, all right, the breathing, the circulation, all right, look at any other disability, okay. Then investigations. Is this patient hypoglycemic? You can do a random blood sugar test, obtain an ABG to look at the ventilation and oxygenation status of this patient. Electrolyte. Most of the times your ABG will give you electrolytes. Renal liver function test depends on the degree of delayed recovery. CT brain if you suspect neurological cause. All right, 3 or 4 monitoring is important. All right, to assess for residual paralysis. We did a case report, when we had, especially during this time when, the movement of Black Lives Matter, all right? After anesthesia, the patient was in recovery room and the patient said, I can't breathe. So the patient stayed longer in recovery room. So 3 or 4 monitoring due to inadequate reversal of residual muscle paralysis. All right, you want to use your drug antidotes. All right, we did say drug overdose. So opioid overdose, you want to reverse with an naloxone, and a patient with benzodiazepine, all right, flumazenil will come handy. And look out for the underlying cause from your investigations and correct appropriately. The important thing is you want to prevent delayed recovery. Okay, delayed recovery. All right, because it increases turnover rate, the time spent both in the OR or in recovery room. So you want to prevent that. Okay, so careful titration of anesthetic drugs. I know some anesthetics who are cowboy anesthetics, they just give those big dose, boost. All right, but I've realized that the best anesthetists are very careful. Shy anesthetists, we don't give too much. All right, we titrate anesthetic drugs, and if it's possible, use your short-acting agents when appropriate. Okay, proper neurovascular monitoring and reversal is important. Okay, vigilant intraoperative monitoring, your oxygenation, ventilation, and temperature. All right. And I hope that many of us in our centers have facilities to monitor temperature. Core temperature monitoring is important. All right. And more importantly, to prevent it, always identify patients that are at risk preoperatively. Okay. The elderly patient, patients with comorbidities, some patients with some abnormalities. All right. These are the ways to prevent delayed recovery. Okay, all the neurological complications, postural puncture headache, we've talked about that before. Yes, awareness under anesthesia, all right, is another very important neurological complications in anesthesia, okay? So the ability for a patient to recall intraoperative events during general anesthesia, all right? Patients, sometimes you have the patient, they'll tell you, I heard them say this, I heard them, and it could be a medical legal issue. So we need to be aware that awareness under anesthesia could be a serious um, complications. It could also have psychological impact on the patient. Okay, so risk factors. All right, I always like mnemonics. Aware, all right. When the anesthesia is light, under what conditions? Emergencies, okay? You want to, all right, patient is bleeding, okay? And you don't want to depress the cardiovascular system. Patients with weak cardiovascular reserves, okay? Patient with ejection fraction less than 25, thereabout. You don't want to give too much anesthesia. Patient with ASA 4, all right? Patients where you have relaxant use, and this is common, all right? Always ensure that your patient is, have proper hypnosis before relaxant. Some patients can be aware, hearing everything, but, they can't move, they can't talk because they are under muscle paralysis. Error of judgment, all right, by the anesthetics provider. Error of judgment. These are some of the common causes of awareness under anesthesia. So there are some signs, all right, there will be signs, all right, signs of awareness under anesthesia. Patient is sweating, okay, tachycardia, hypertension, okay, lacrimation, okay, all right, these are some of the signs. Okay. It's important that we understand this, okay? Vigilant monitoring is important. Your biceptular index, all right, by biceptular or entropy. Biceptular, it's a derivative of your EEG, okay, and it's important. It gives you notive values, okay. By biceptular index score of 40, all right, usually, is enough for adequate hypnosis. All right, pre-medication ensure, especially with your benzodiazepines, helps to prevent awareness under anesthesia. Actually, awareness under anesthesia is a topic on its own, and this is just a summary. So how do you manage it? Preoperative awareness, identify patients at risk from your history taking. All right. Intraoperatively, you want to do pre-medication with your benzodiazepine and monitoring the depth of anesthesia. All right. So how do you do monitoring? How do you monitor the depth of anesthesia? You want to look at the autonomic changes. Look at the heart rate, look at other autonomic function like sweating and all that. Isolated forearm technique. I hope we know how to do this, okay? You put your BP cuff around the arm and you inflate it above systolic blood pressure for the patient before you give your muscle relaxant, okay? And intraoperatively, you can tell the patient, just ask, can you move your arm? Move this arm. And if patient can move the arm, the patient is aware. Okay, that's what we mean as isolated forearm technique. Okay, spontaneous electromyography, lower esophageal contractility. All right, especially all right in patients who are intubated, you put your NG tube like structure and you put it in the lower esophageal and you see the contractility to measure whether the patient is adequately, under anesthesia or not. Heart rate variability, we talked about the EEG derivatives, your biceptal index score, or your auditory evoked potentials. In fact, auditory evoked potential is is the is the evoked potential that is readily used, especially in monitoring awareness. So if you're in an exam and you are asked how do you monitor depth of anesthesia, you just need to mention some of these things and make sure you're able to describe isolated forearm technique, lower superficial contractility, your biceptal index score, and your autonomic, auditory evoked potential. All right, these are very crucial. Okay. Now, temperature regulator, we've talked about this. Temperature regulates, related, perioperative hypothermia, all right, when you have a core temperature less than 36. And that's why I said I hope we have, facilities to monitor core temperature in our theaters. So how does perioperative hypothermia develop? Normally due to anesthesia-induced vasodilatation, all right, which leads to redistribution of heat from the core to the periphery, so lowers the core temperature. All right, patient under anesthesia has lost behavioral regulation. All right, so to deal with hypothermia, they can't shiver, they can't cover themselves. All right, the cold ambient theater environment. Okay, I've heard a lot of surgeons complain, I'm sweating, it's too hot. All right, a lot of times we need to balance, staff or faculties' comfort and patients' safety. Administration of cold IV fluid or gases. All right, make sure you warm your fluids or at least room temperature and humidify all your gases that you're giving to this patient. Okay, what are the risk factors? Elderly patients and neonates, patients with prolonged surgery or large exposure site, patients and having what is it called? Intra-abdominal procedures. Okay, patient with neuralgia blocks. Okay, these are some of the risk factors for perioperative hypothermia. It's important that we know these risk factors so that we can prevent hypothermia. All right, there are a lot of risk factors, complications, coagulopathy, all right, a wound infection, all right, delayed drug metabolism, and shivering. We'll talk about post-anesthetic shivering in the course of the discussion today. All right, shivering increases oxygen demand, okay, and it puts a lot of pressure or toll on the heart. Cardiac arrhythmias, these are some of the complications of hypothermia. So how do you do it? You prevent pre-warming. Okay, make sure your patient is warmed. All right. Sometimes, especially in neonates and pediatric patients, we usually increase the ambient temperature. All right, above what is obtained in other common theaters. Okay, and if you're having a patient who is elderly, you need to also raise the ambient temperature. First, air warming blankets. All right, especially for neonates, it must be present in the theater. Warm your IV fluid and gases and ensure you have, a good control of the operating room temperature. All right, so a very important temperature regulated complication is the MH, malignant hyperthermia. Okay, malignant hyperthermia is although rare, but a life-threatening pharmacogenetic disorder of the skeletal muscle metabolism, usually triggered by certain anesthetic agents, and this leads to uncontrolled hypermetabolism, muscle rigidity, and a rapid rise in body temperature. Okay. I remember last week somebody was telling us that they had experienced one in National Hospital Abuja. Okay, and I did encourage him to write a case report on that. I'll be interested. So, uh, malignant hyperthermia is caused by a defect in the ryanodine receptor on the sarcoplasmic reticulum. All right. So certain volatile agents like your sevoflurane, isoflurane, in combination with suzametonium, all right, triggers for MH. What happens is that because of this defect, there's excessive release of calcium into the myoplasm, which leads to sustained muscle contraction, all right, heat production, and hypermetabolism. All right. So, what are the features you will see in theater when you have a rapid rise in end-tidal CO2? All right, this is showing hypermetabolism. A CO2 that is as high as 55, 65. All right, sometimes it can be even as high as 70 millimeters of mercury. All right, you want to find out, especially in association with hyperthermia. All right, when the core temperature is more than 38.5 degrees Celsius. Now, this is coupled with muscle rigidity, especially the masseter muscle, and you have tachycardia, arrhythmias, and your ABG is showing metabolic and respiratory acidosis and all of that. Hyperkalemia from rhabdomyolysis with myoglobinuria. These are some of the pointers, but the two most important features, two most important early features is the rapid rise in your end-tidal CO2 and hyperthermia. These others may or may not be there. But when you have a rapid rise in your end-tidal CO2 in association with hyperthermia, this patient should be treated as a case of malignant hyperthermia. All right. So how do you diagnose? It's primarily clinical based on the above features we mentioned. Capnography will show a rapid rise in ATCO2. Then you can do a confirmatory test, okay, outside the acute setting. And you can do the caffeine halogen contracture test, all right, the CHCT test. Or you do the ryanodine receptor typing, all right, and it will make a diagnosis for you. So, how do you manage a case of MH? You want to stop the triggering agent, all right? Convert to, if it's inhalation and you want to convert to TIVA, all right? Then call for help. Administer dantrolene. I think I was asking last week if we all have dantrolene in our emergency tray. Okay, dantrolene 2.5 milligram per kg IV. You can repeat as required. Then hyperventilate with oxygen. This is an attempt to blow off some carbon dioxide and ensure adequate oxygenation. Rapid cooling. Make sure you cool the patient. All right, both surface cooling and administer IV fluid, cold IV fluid. All right. Then you treat any arrhythmias that may have arisen and correct acidosis and manage your abdominalysis, especially with rapid infusion of fluid. All right. This patient shouldn't be allowed to go to the ward. Make sure you arrange for an ICU admission for this patient. Okay. So prevention is better than cure. It holds true, especially in the case of MH. All right. So I wonder how many of us usually take history of MH from our patient. How are you going to ask? All right. MH susceptible patients should have, all right, a label, all right, and their family members. Okay. And once you are able to identify you want to use not triggering agent, your TIVA is important, especially in non-MA susceptible individuals. Like I mentioned, dantrolene availability is mandatory in all facilities that offer general anesthesia. Okay. Yes, this is another very important complications. We have 20 minutes and I still have about 31 slides. Let's see how we go. Okay. Now, post-anesthetic shivering, it is one of part of my dissertation topics, all right, in 2009. Okay, 2008, 2009, post-anesthetic shivering is a common post-operative complication, especially during emergence from anesthesia and in the post-anesthetic care unit, all right? The incidence varies very widely between 5 to 65%. of patients, you know, undergoing general anesthesia, and it can be as high as 30% following neoasia anesthesia. All right, the common causes of post-anesthesia shivering PAS is also PAS. All right, post-operative perioperative hypothermia. All right, it's a very common cause of post-anesthetic shivering. Post-operative pain. Yes, post-operative pain. All right, anesthetic agents that reduce the body's natural ability to regulate its temperature. All right, there's some apnoid and epidural blocks. And don't forget smokers. All right. I remember we talked about Apfel the last week. I hope we're going to talk about it here. Okay, so how does post-anesthesia ring develop and show? All right, usually it's in response to call hypothermia of less than 30 Cs. All right, there will be thermoregulatory shivering. This most of the time is due to the anesthetic-induced vasodilatation coupled with the cold theater environment and heat loss from exposed surfaces. Non-thermoregulatory mechanisms include spinal reflexes, pain, systemic inflammation, and the anesthetic drugs. So what are the clinical consequences? Post-IMC shivering can increase oxygen consumption to up to 400 to 500%. And that is why when the patient is having post-IMC shivering, you want to give supplemental oxygen. Okay? There could be increased carbon dioxide production, leading to increased cardiac output, exacerbation of patient, and very, very important, it leads to patient discomfort and distress. In fact, some patients have considered post-anesthetic shivering and post-operative nausea and vomiting are two very important fear of anesthesia, not even the surgery itself, not the fear of dying from drug overdose, but the fear of POMV and post-anesthetic shivering makes a lot of people very apprehensive about anesthesia. All right, don't forget that it can also interfere with monitoring, all right, with your ECG leads falling apart and pulse oximetry. Okay, so how do you recognize it? Visible muscle tremors, all right? There's associated hypothermia, okay? It may mimic rigor seizures, so you need to have a high index of suspicion. So, post-anesthetic shivering can be managed non-pharmacologically and by pharmacological means, okay? Non-pharmacological ways, active warming devices. Okay, first air warmers like a beer hooker we talked about. All right, warming blankets, warm IV fluid, and maintain operating room temperature. All right, I was going to ask someone, but because of time today, I wanted to ask someone what is thermoneutral environment? What do we mean by thermoneutral? So somebody get ready to answer that towards the end as we finish. Thermoneutral environment. Okay, pharmacological means petidine, all right, is the gold standard. Okay, and pentazocine, physostigmine can be used. Active warming of fluid, alpha 3 central agonist, your clonidine, and desmetomidine. Desmetomidine is actually a wonder drug because apart from its sedative, it has an analgesic property and it also has anti-shivering property. So desmetomidine, especially for patients undergoing day case surgery or monitor anesthesia care, desmetomidine may be your drugs. All right, maybe your drug of choice. Steroids. All right, dexamethasone has been used. All right, as an adjuvant in the management of post-anesthetic shivering. Yes, POMV, the brother. I feel it's for POMV, okay? Do you have, what is this? Okay, POMV. I think we talked about this last time. Okay, I won't take long here. All right, is nausea or vomiting occurring within the first 24 hours after surgery? where it can affect up to 30% of all surgical patients. And in high-risk patients like the female FAT40 with family history, it can lead to 70 to 80%. Okay, so what are the causes? All right, patient factors, the four F's we mentioned. Patients undergoing ovarian ophthalmic procedures. Okay, patients where we have the procedure where you have nitrous oxide use or neostigmine. Ventilation with mask, which can lead to increased gastric distension. Okay, I think we talked about this. Okay, let's look at postoperative cognitive dysfunction. Postoperative cognitive dysfunction. All right, this refers to a decline in cognitive function that occurs days to weeks after surgery, particularly in elderly patients. A decline in cognitive function, all right, or executive function that occurs days to weeks after surgery, particularly in elderly patients. It's been said to affect up to 40% of all elderly patients at the time of discharge. And unfortunately and painfully, it may persist in about 10 to 15% of patients at 3 months after surgery. What are the risk factors of post-operative cognitive dysfunction? Is the age brain, okay? The brain is old. Okay, age, elderly patient, patient undergoing general anesthesia, emergency surgery, patient with brain disorders, all right, like dementia, patient with respiratory complications, anemia, infection, neurological insults. These are some of the common risk factors for developing postoperative cognitive dysfunction. Clinical features, don't forget the 4Ds, okay? A silent drift in the mind after surgery, the 4Ds, all right? All right, the 4Ds of postoperative cognitive dysfunction. There's disorientation. Patient is confused about time, place, and identity, all right? There's difficulty with concentration, all right? Inability to maintain focus or attention. There's delayed mental processing. All right, the patient is slow to think and gives delayed response. Patient can be depressed. You can have depressive moods, sometimes with irritability, anxiety, apathy, or emotional lability. Okay, these are the 4Ds of postoperative cognitive dysfunction. So prevention is usually better than managing this patient. Careful anesthetic planning in the elderly. Avoid deep sedation or over medication. Early mobilization and orientation post-op. All right. You know, it's important. I tell people, talk to your patient. Oh, we're going to put you to sleep now. Oh, surgery is over. It went well. You did beautifully well. Can you open your eyes? You know, reunite them with their family as soon as possible. Oh, your wife, your husband, your children, they are waiting for you in the recovery room. Make sure you engage the patient as you, uh, you know, put them to sleep and as you wake them up from anesthesia. Engage them. It helps in early reorientation of this patient post anesthesia, especially in elderly patients. The number of us have come across me now after surgery say, where am I? All right? Because we were not told, oh, you just had surgery. All right, surgery went well. You remember you had you were in the bathroom, you fell and you broke your hip, and now the orthopedic surgeons have helped you to put it back and all that, just talk to the patient, especially elderly patient. Okay, drug reactions in anesthesia. I think we mentioned that. I don't know if we can go there. Okay. Let me just talk about latest, okay, anaphylaxis. Oh my God, time is going. Anaphylaxis, okay, does occur in anesthesia, all right? It is a severe life-threatening systemic hypersensitivity reaction, typically mediated by the IgE, and occurs suddenly and can involve cardiovascular collapse, bronchospasm, skin or mucosa changes. Know that it can be very difficult to recognize, all right, during anesthesia due to the effect of your drugs and the drippings. Okay? So when you have sudden hypotension, bradycardia, bronchospasm, and all of this after you give a medication, you must suspect anaphylaxis. Okay, some common triggers, your neuromuscular blockers, all right, especially rocuronium, okay, and suzametonium. Antibiotics like your beta lactam producing antibiotics, your penicillin, cephalosporins, latex, your gloves and catheters, colloids, induction. These are common triggers in anesthesia. So what do? You want to stop the suspected drugs? Call for help, secure the airway if the patient is not already intubated, 100% oxygen, and ventilate the patient. Give the patient rapid IV fluids, all right, and give this patient epinephrine, IV or IM, whatever you have. Then antihistamines, all right, your chlorpheniramine and all that, and steroids could be adjuvant. But if the patient have cardiovascular collapse, be ready to prepare for CPR and initiate it. Okay, post-event care, admit to ICU for observation. All right, you want to take blood for tryptase levels. All right, refer for allergy testing. Okay, and document the event and all that. Okay, so latex allergy is a common cause of anaphylaxis. All right, in anesthesia. All right, it is an IgE-mediated hypersensitivity reaction to proteins found in natural rubber latex. And this is what is commonly used in our gloves, catheters, and airway devices. A latex allergy can range from mild contact dermatitis to severe anaphylaxis during anesthesia. All right, you and I are at risk. Those of us that use gloves regularly, okay, in ICU, in theater. All right, patients with spinal bifida urogenital anomalies that usually require frequent anesthesia and surgery. Multiple surgery, especially from infancy. Patients who have known allergies to bananas, avocados, and all that. These are patients that are high risk of latex allergy. All right. So clinical features usually type 1, okay. All right, the skin, respiratory, cardiovascular, and all that. And you can call intraoperatively or perioperatively, often during catheterization or glove exposure. So beware of latex allergy. Okay, so if I remember there was a part one exam those days that talked about latex allergy. So what are your anesthetic considerations? I give you a case scenario: a 25-year-old patient coming for a repeat surgery. Okay, and I had 3 surgeries under general anesthesia in the last 2, 3 months, and is coming for a relook, and he has history. In the last surgery, he had history of latex allergy. Okay, so um, you're planning for anesthesia for this patient. So the question is, what are your anesthetic considerations? Okay, so you want to use latex-free gloves. They're available. Make sure that all your equipment you're going to use are latex-free. They have a post catheter airways. Okay, then make sure you schedule this patient. They will be the first case to avoid contamination. Okay, label clearly as latex allergic, and make sure you have your anaphylaxis treatment ready. Minimize skin and mucosa exposure. Okay, so these are your anesthetic considerations for a patient coming for surgery with a known latex allergy. Okay, key clinical X-ray is key, and make sure you confirm with skin prick test or serum latex specific IG. Okay, when it occurs, immediate cessation of latex exposure and treat as per anaphylaxis protocol. I think I'll need to stop here. Positioning. Okay, the common position-related injuries are the peripheral nerve injury, pressure ulcers, compartment syndrome, especially following patient in lithotomy position, ocular surgery, ocular injuries from prone position and all that. Okay, all right. So conclusion, yes, I'm here. Anesthesia-related complications, though often preventable, can range from minor to life-threatening and involve various systems such as the airway, like we mentioned, respiratory, cardiovascular, neurological, and immune. So a clear understanding of the risk factors, vigilant monitoring, prompt recognition, time intervention are essential to minimize harm. These are the what's it called? The references. All right. Do we? I hope we all heard me. How many of you slept off?
I didn't sleep. I'm here.